Welcome to Lesson 6. At this point in the course, you've built a strong foundation in understanding addiction from multiple angles. You already understand the disease model, the neurobiology behind the substance use. You understand the biopsychosocial factors that are influencing behavior and the progression of addiction. And you're also understanding the relapse and recovery process. And now we want to move into one of the most important areas of your role as a counselor, which is treatment planning and intervention. This is where all of that knowledge is coming together in a practical and structured way. Understanding addiction is important, but knowing how to respond to it in a clinical setting is what's going to make you effective. And treatment planning is not just paperwork. It's not just something that you complete to meet a requirement. It's the roadmap for how you're going to work with your client. It's guiding your sessions and your interventions, and also it's guiding your decision-making process. And when treatment planning is done well, it's creating clarity for both you and the client. And when it's done poorly, it's leading to confusion and a lack of direction and inconsistent care. So I want you to think about your current approach to treatment planning. Do you see it as a task to complete, or do you see it as a tool to guide your work? This lesson is going to shift your perspective if needed. We're going to break down how to build meaningful, individualized, and clinically useful treatment plans. And we're also going to focus heavily on interventions because a plan is only as good as what you actually do with it in a session. And by the end of this lesson, you should feel more confident, not only in writing your treatment plans, but in using them as a living part of your clinical practice. So before we move deeper into the content, I want to clearly outline what you should be able to do after completing this lesson. First, you need to understand the true purpose of treatment planning. This really goes beyond documentation. It's about creating a structured and intentional approach to helping your client change their behavior. Then you need to be able to build an individualized treatment plan. And that means moving away from the generic templates and towards plans that actually reflect the client sitting in front of you. Every client has different needs, and your plan should show that. And then third, you should be able to select appropriate interventions. This is where a lot of counselors struggle. They may know what the problem is, but they're not always sure what to do about it in session. So this lesson is going to help bridge that gap. And then finally, you should be able to apply your treatment plan in real sessions. So a plan sits on paper, is never referenced, that's not effective. The plan should really be guiding your conversations and your focus and the goals of the sessions. So as you're going through this lesson, I want you to think about how you're currently approaching each of these areas. Where do you feel confident? Where do you feel uncertain? And that awareness is going to help you get the most out of that material. So the goal is not perfection here. The goal is just to improve and consistency in your clinical work. So a treatment plan is best understood as a structured roadmap for care. So it's taking the information that you gathered during assessment and it's organizing it into a really clear plan for how you're going to help the client to move forward. This is not just about identifying problems. It's about really just defining the goals and outlining the steps needed to reach those goals. And so one of the biggest mistakes that counselors make is treating the treatment plan as a static document. In reality, the plan needs to be dynamic and responsive to the client's progress. So like a treatment plan should really guide your clinical work, not just sit in the client's file. And when you walk into a session, you should already have a sense of what you're working toward and how that connects to the plan. Another important point is that treatment plans should be understandable to the client. If the client can't explain their goals or maybe doesn't see how the plan applies to them, then the plan's not effective. And this is where collaboration becomes important. The client should have input in the goals, and they should feel ownership over the process. And from a clinical standpoint, a strong treatment plan is going to help you stay focused. It's going to prevent the session from becoming unfocused and reactive. And it also helps you measure the progress over time. Because without a plan, it's going to be difficult to know whether the client is improving or just simply maintaining. And so as we're moving forward, we want to go, break this down into very practical steps so you can create plans that are both clinically meaningful and easy to use in your everyday work. And treatment planning, it really matters more than a lot of counselors initially realize. It's not just a requirement for agencies or insurance. It's a core part of effective clinical work. Because first, it's providing the structure. Without a plan, the sessions can easily become reactive, meaning you're only addressing whatever the client brings up in the moment without connecting it to the long-term goals. And while flexibility is important, a lack of structure can lead to minimal progress. And then second, treatment planning is going to improve the outcomes. When the goals are clear and the interventions are intentional, the clients are more likely to make meaningful changes. And then third, it's ensuring consistency. If multiple providers are involved, a clear treatment plan is going to help everybody stay aligned. Even if you are the only provider, it's going to help you maintain continuity from one session to the next. And then fourth, it's going to support accountability for both you and the client. You both know what you're working toward and what steps are being taken. And that's going to make it a lot easier to identify when the progress is happening and when we need to make adjustments. So I also want you to think about here how the treatment planning impacts your confidence as a counselor. When you have a clear plan, you're less likely to feel stuck or unsure in sessions. You have a direction, you have a purpose, and that confidence translates into stronger sessions and better outcomes for your clients. And a strong treatment plan is going to have several key components, and each one is going to play a specific role in guiding the clinical process. So the first component is identified problems or needs, and these should come directly from your assessment, and they need to reflect the areas that require intervention. So does the client have housing? Do they have access to transportation, access to healthcare? Do they have access to, a working stove? Are they feeding themselves? What's their support system like? Where do we need to intervene? And then the next component is clear goals. Goals should describe the overall outcome that you're working toward. Is the client trying to achieve sobriety or improve their emotional regulation? Or are they trying to stabilize their mental health? The goals alone are not enough, though, because they need to be supported by measurable objectives. Objectives are going to break the goal down into smaller, more observable steps that can be tracked over time. So, for example, instead of saying client will improve coping skills, a good objective might be like client will identify and use 3 coping skills during high-risk situations. We want it to be more specific. And specific interventions, these are really critical for the client and for you. This is where you're going to define what you as the counselor are actually going to do in sessions. Maybe it's cognitive behavioral therapy techniques or relapse prevention planning, psychoeducation, or trauma-informed interventions. So whenever we do a treatment plan, it's going to have the goal, which is the overarching goal, and then it's going to have the objectives underneath there, and then underneath that it's going to tell what interventions we're going to use to help the clients get to that goal and complete each one of those objectives. So a strong treatment plan is going to include a timeline and regular reviews. So on your treatment plan, we need to have this particular goal is going to be reached by XYZ date. And we need to have a review date so that we can go back and say, okay, have we met this goal or do we need to continue working on it? Is there anything else that we need to work on? Are you nearing completion of the program? Like, treatment's not static. The plans have to be revisited and they have to be updated based on the client's progress and their changing needs. And I understand that it's very difficult in a ASAM level 1 outpatient treatment program to do the updated treatment plans as needed for short-term clients, because the short-term clients are only there 6 weeks or whatever, and it's very difficult to set this as like, okay, I need to look at this and do this on a regular basis. But with our longer term clients, this is something that we definitely need to do. And I think the standard review is like every 90 days. So plans, we need to update them, and revisit them based on, is the client progressing? How has the client progressed, and how have their needs changed since we started this? We need to see it as an active process rather than just a one-time task. Every component should connect logically to the others and create a clear and cohesive plan. So now we're going to shift into the levels of care, which is what I was just kind of alluding to. This is where treatment planning becomes even more concrete. The levels of care are going to refer to the intensity and structure of treatment that the client's receiving. And not every client needs the same level of care. So part of your role is determining what is appropriate based on their needs. And that's where a lot of counselors feel uncertain, especially early on in their careers. They may, know that a client needs help, but they're not always sure how much help or what type of help. And so the levels of care help answer that question. They range from early intervention, which I call relapse prevention too. So it's either early intervention, relapse prevention, and that's usually typically done in outpatient services, to more intensive options like intensive outpatient programs, partial hospitalization programs, residential treatment, detox. It's really important to understand that levels of care are not fixed. A client may move between levels based on their progress or their setbacks. I've seen some people in partial hospitalization drop down to an intensive outpatient and then have to go right back to detox. So this is why ongoing assessment is critical. As counselors, we need to be comfortable adjusting recommendations as needed. And one of the most important things to remember is that levels of care are based on clients' needs, not convenience, not availability, and not assumptions, not what your program says that they offer, not what probation said that they needed to do. This is what's needed, not what's required. And that's going to require honest assessment and sometimes very difficult conversations with upper management, with your clients, with probation officers. Some of these conversations have been very difficult in the past. You may need to recommend a higher level of care even if the client is resistant. Being able to explain and justify that recommendation is part of your role. So the ASAM criteria is one of the most widely used frameworks for determining levels of care in substance use treatment. Even if you're not formally completing ASAM assessments, understanding the framework is going to significantly improve your clinical thinking. So ASAM is built around 6 dimensions. Each one is evaluating a different aspect of the client's functioning and their risk. And these dimensions include acute intoxication and withdrawal potential, biomedical conditions, emotional and behavioral conditions, what's their readiness to change, what's their relapse potential, and their recovery environment. And together, these dimensions are providing a comprehensive picture of the client's situation. So the goal is not to diagnose the problem, but to determine the appropriate level of care. Because ASAM focuses heavily on risk and functioning. So it asks questions like, how stable is this client? What risks are present? What level of support is needed? And this is especially important in cases where safety is a concern. So as counselors, we should be thinking in this type of framework even when we're not documenting it formally, because it helps us move from just a general impression to structured clinical reasoning. And it also strengthens our ability to justify our recommendations to other professionals. And trust me, I've had to justify my recommendation to other professionals, like probation officers. So ASAM Dimension 1 focuses on acute intoxication and withdrawal potential, and this is one of the most immediate safety concerns in treatment planning. When we evaluate this dimension, we're asking whether the client is currently under the influence or are they at risk of withdrawal? And if so, how severe that withdrawal might be. This is not just a clinical preference issue. This is medical safety issues. Certain substances like alcohol or benzodiazepines, they produce life-threatening withdrawal symptoms. So as my clinical supervisor used to tell me, you better hope that, it's withdrawal from heroin and not withdrawal from alcohol. If I am admitting people, and I have one person come in withdrawing from cocaine, one from heroin, and one from alcohol. I'm admitting the one from withdrawing from alcohol, just because it is a life or death situation there. Because withdrawal from alcohol and benzodiazepines, while it may not be immediate, within that first week or two, they are at risk of dying from the withdrawal symptoms. And if a client is at risk for severe withdrawal, outpatient treatment is not appropriate. They need to go to medication-assisted detox. Or some other higher level of care where they can be monitored. As counselors, we need to be able to recognize these risks and respond appropriately and immediately. This may involve asking detailed questions like, how frequently do you use? How much do you use? Like, what's the amount? What's the duration? Like, how often are you doing it? How long are you doing it for when you use it? Have you experienced any past withdrawal symptoms? Maybe this involves coordinating with medical professionals. One of the biggest mistakes in this area is underestimating withdrawal risk. Clients might minimize their use or not fully understand the severity of the withdrawal, and that's where your assessment skills are critical. You need to gather enough information to make an informed decision. So Dimension 1 is often the first filter in determining level of care because safety comes first. If I have a client that's withdrawing from benzodiazepines, we're not going any further in the assessment. I'm immediately stopping it and I'm referring you over to a detox center. And I'm going to call and we're going to do a warm handoff and I'm going to make sure that I get you over there because it's vitally important. Your life is on the line. ASAM Dimension 2 is going to focus on biomedical conditions. And this is an area that's often unaddressed or underaddressed by counselors who are just primarily focused on the behavioral health. But, physical health does play a major role in substance use and recovery. So when we evaluate this dimension, we're asking, does the client have any medical conditions that could impact their treatment or their recovery process? So maybe it's a chronic illness like diabetes or hypertension, liver disease, respiratory conditions, HIV, AIDS, whatever. And it also could be like acute issues like injuries or infections or just untreated medical problems. And so one of the most important questions to consider here is whether the client is stable enough to even participate in treatment at the given level of care. For example, like a client with severe unmanaged medical conditions may not be appropriate for standard outpatient treatment if those conditions are going to interfere with them being able to attend or engage or, their safety in general. And then another important factor here is medication. Is the client taking medications as prescribed? Are there interactions between the medications and substances that they're using? Are there barriers to assessing, medical care, like a lack of insurance or transportation? As counselors, we're not expected to diagnose and treat the medical conditions, but we are responsible for recognizing when they're relevant and coordinating the care when needed. So you might say to a client, I'm hearing that your health issues are making it hard for you to stay consistent in treatment. So let's talk about maybe how we can address that alongside your recovery. Because this dimension is reminding us that recovery doesn't happen in isolation from the body. So the physical health and the substance use are very closely connected and both need to be addressed for the treatment plan to be effective. ASAM Dimension 3 focuses on emotional, behavioral, and cognitive conditions. And this is where a large portion of your counseling work is going to live. When we evaluate this dimension, we're looking at mental health symptoms, behavioral patterns, overall emotional stability. And that's going to include conditions like depression or anxiety, bipolar disorder, PTSD, and other co-occurring disorders. And it's also going to include behavioral issues like impulsivity, aggression, difficulty regulating your emotions. But one of the key questions that we need to ask here is, how do these conditions impact the client's ability to engage in the treatment and maintain recovery? So, for example, a client with severe depression might struggle with motivation and coming to, the sessions and following through on the things that we're asking them to do. And a client with untreated trauma may use substances to cope with those overwhelming emotions. Maybe a client with significant anxiety may avoid situations that are actually helpful for their recovery, like going to AA and NA meetings. So, as counselors, we need to assess both the presence and the severity of these conditions. I have a client, or had a client in the past that he was dealing with PTSD, and he had a lot of family history of trauma, and he did not want to do the group sessions. He wanted to do individual sessions. And so I let that go for a little while. The goal in doing the individual sessions, because we know research says that, group sessions for substance abuse are the most effective form of treatment. So the goal that I had in mind for him, and I talked to him about early on, was, hey, we want to move you into a group setting, because this is the most beneficial place for you to be. Listening to me mumble on and on is great, but hearing other people and understanding that you're not alone in this is the biggest piece of treatment. And so we did the first 3 sessions individual, and then we moved him over into a group session, and that seemed to work out really well for him. We also need to consider whether they're, being treated. Is the client engaging in mental health services? Are they taking their prescribed medication? Are they seeing psych? Are they going to an individual therapist? Are those interventions even effective? This dimension often requires collaboration with other providers, like psychiatrists and therapists. And one of the biggest clinical mistakes is treating substance use without addressing that underlying mental health issue. We always say address substance first, but sometimes we need to address mental health and substance at the same time. So maybe we might say to a client, hey, we can work on the substance use, but we also need to address the anxiety that you've been dealing with, because that's part of what's driving the behavior. So this dimension reinforces the need for that integrated care. ASAM Dimension 4 focuses on readiness to change. And this is where your motivational interviewing skills are going to become especially important. Not every client comes into treatment ready to fully engage. Some are there because of external pressures, like probation or court orders or family expectations. Others may be ambivalent, recognizing some problems but not fully committed to the change. And when we evaluate this dimension, we're not asking, how ready is this client to participate in treatment and make changes. This is really not a judgment, it's an assessment. A client who's not really fully ready doesn't need to be labeled as resistant. They need a different approach, and that's where we're meeting the client where they're at. So, like, for example, if a client were to say, I don't think my use is that bad, your job is not to argue. Your role is to explore. So maybe you might respond with, okay, so help me understand what feels manageable about it to you and where you've seen it cause problems. I want them to look at both sides of the coin. So that's why I'm asking for both sides of the coin. We're opening up the door for conversation rather than confrontation. I want them to tell me what they're seeing, because I see it, but maybe they don't. So they need to explore that. Readiness to change also impacts level of care decisions. So a client with low motivation may need more structured and intensive services to support engagement. And then on the other hand, a highly motivated client may do well in a less intensive setting. So as counselors, we need to continuously assess and respond to motivation. It's not static, it's going to change over time, and our approach should adapt accordingly. ASAM Dimension 5 is focusing on relapse potential. And this is where everything you've learned in the previous lesson directly applies. So when we evaluate this dimension, we're asking how likely is this client to continue using, or how likely are they to return to their use without the intervention? And this kind of involves looking at past patterns. What are their current triggers? What's the client's ability to cope with their stress and their cravings? A client with multiple past relapses, and they don't have very many coping skills, and they're highly exposed to triggers, that's a high risk situation. Then on the other hand, like a client with strong coping skills and they have a supportive environment and they have fewer triggers, they're at lower risk. So it's important to remember that relapse potential is not just about history, it's also about their current functioning. So a client may have a long history of use, but be in a stable and supportive environment with strong motivation. Then on the flip side of that, there's the client with a shorter history may be at high risk because of their current stressors and a lack of support. So, as counselors, we got to assess this dimension carefully and honestly. And that's going to require us asking some pretty detailed questions about past relapse experiences. So maybe we ask, what was happening right before you returned to use? Or what made it difficult to stay consistent at that time? And that helps to identify patterns that inform the treatment planning. Dimension 5 is one of the most important factors in determining level of care because it directly relates to risk. And then Dimension 6 focuses on the recovery environment, and this is one of the most practical and influential aspects of treatment planning. When we evaluate this dimension, we're looking at where does the client live? Who are they interacting with? What are their daily environments looking like? A supportive environment can significantly improve the chances of recovery. So maybe that includes stable housing, or maybe they have supportive family members or access to resources, whatever. Maybe they already have some coping skills on hand. Maybe they already attend AA and NA. That would be part of the environment. On the other side of this, though, a high-risk environment can undermine even the best treatment plan. So this might be like living with people who are using substances, being in a community where substance use is common, lacking access to basic needs. As counselors, we need to assess this honestly and don't assume anything. So you might ask questions like, who do you live with? What's a typical day like for you? Are there situations where you feel more at risk? Some of the questions that I ask when I'm doing this type of assessment is, do you live in a house, a trailer, a townhome, an RV? You'd be surprised at how many people will tell you that their housing is stable, but they're living in a RV or they're renting a room from a family member, and none of that is stability. Okay. Sometimes they I just stay with my parents. That's not technically stable, especially for grown adults. All right. Do you have health insurance? That's another, environmental thing. Are you working? Do you have a roommate? Who lives there with you? Are they using substances? I'm going to ask all of these tough questions, and it may seem very invasive, but I'm trying to get a picture for what this person is going through in their day-to-day. This information is going to help us determine whether the current environment is supporting or hindering their recovery. In some cases, the environment may need to change. I have absolutely pulled people out of their environment and told them you're going inpatient. We may need to recommend sober living or increase the support or change their social connections. In other cases, the focus may be on just helping the client develop strategies to navigate their current environment a little bit more safely. For the person that doesn't have a reliable transportation. Well, do you live near a bus line? Do you have the ability to use Uber? Do you have family members that can drive you where you need to go? I'm going to start asking and prodding a little bit further to make sure that they can navigate that environment more safely. And then Dimension 6 reminds us that recovery doesn't happen in a vacuum. It's influenced by everything around the client. If the client is not working, they're living around people who are using, their friends are using, that client has a high risk of relapse just straight off based off their environment. There's no stake in conformity there. There's no job to lose. There's no housing to lose. Their family members are using with them, so they're not going to lose their family members or their support system. So now that we've gone through all 6 dimensions, the next step is learning how to integrate them into a cohesive clinical picture. The goal is not to treat each dimension separately, but to understand how they're interacting. So, for example, a client may have moderate withdrawal risk. Maybe they have severe mental health symptoms, low motivation. Maybe they have a high relapse potential and a high risk environment. And when you look at that combination of things, it becomes clear that a higher level of care may be necessary. And then on the other hand, a client with mild withdrawal risk and stable mental health and high motivation, they have a low relapse potential and a supportive environment, they may be appropriate for outpatient treatment. Integration is where clinical judgment is going to come in. This is not about scoring each dimension and adding them up. It's about understanding the overall picture. So as counselors, we need to be able to explain our reasoning clearly. And this is especially important in legal or professional settings. So we might say something like, based on the client's high relapse potential, their low support and moderate mental health concerns, a more structured level of care is recommended. And that kind of statement shows that your decision is based on clinical reasoning, not just guesswork. Integration is what's turning information into action. Now, let's connect the ASAM dimensions to the actual levels of care. At the lower end, we have early intervention, and this is often referred to as level 0.5. This is what people call risk reduction school or DUI school. It's psychoeducation, basically. It's appropriate for people who are at risk but not yet experiencing significant impairment. And then there's outpatient treatment, or level 1, which is typically involving regular sessions, but it allows the client to continue their daily life. And so this is between 3 and 9 hours weekly. Intensive outpatient programs, or IOP, provide the most structure and require more frequent participation, often several times a week. So we're seeing this at 9 to 20 hours per week. So at the higher end, we have residential or inpatient treatment. Actually, let me back up here, because we also have day treatment centers. So this is partial hospitalization. They're going like Monday through Friday, 9 to 5. They're having once a week case management sessions. They're doing daily 12-step meetings. They may even live in sober living afterward. But on the higher end of this, we have like the residential or the inpatient treatment. So there's several, like 3.2, 3.4, 3.5, 3.7, so it kind of depends on the level of care of the residential or inpatient treatment, how long it is, what's involved with it. But this is typically 24-hour support and structure. And then level 4 would be detox. So this is all day long medication assistance. There is a level 3 that does have medication assistance, but level 4 is detox. And each level of these of care is going to serve a different purpose. And the goal is to match the client to the level that's best meeting their needs. So this is where your ASAM informed thinking comes into play. We're not just choosing a level of care randomly, we're not just choosing a level of care based upon, my company provides this level of care, so this is the level of care you're getting because you came to me for an evaluation. No, we're making a decision based on the severity, the risk, and the support. And so as counselors, we need to be comfortable recommending higher levels of care when it's appropriate, even if the client is hesitant. Clients are going to be hesitant. They don't want to be locked away. We get that. But it's for your own good. Our responsibility is to provide the best clinical recommendation based on the information that we have. So matching a client to an appropriate level of care is one of the most important decisions that we're going to make. And it's going to require careful consideration of multiple factors. Severity of use is a major factor. Clients with the more severe patterns of use often require more intensive treatment. Risk of relapse is another key consideration. A client who's at high risk may need more structure and support. Stability of the environment is going to play a big role. The client in a high-risk environment may not do as well in a less structured setting. And then, the client's ability to function is important. Can they maintain employment? Can they attend sessions consistently? Can they manage their daily responsibilities? These questions are going to help you guide your decision. Because I know that I had a client recently who struggled with depression, and she was isolating severely. She's pushing her support system away. She's continuing to use, not frequently, but she's still continuing to use despite multiple legal issues, despite family issues and health issues. And so I know that she doesn't drive, and she has a difficult time with using technology, so she's not going to be an appropriate fit for outpatient treatment. She's going to need intensive outpatient at that point because she's isolating. We need to redefine her support system. We need to get her out of her zone and into some sort of treatment and something that she's going to be able to engage with, because she's not going to be able to engage in outpatient treatment once a week, doing it virtually, and she's not going to drive to these centers to make it to the meetings once a week. Her depression and anxiety are going to prohibit her from doing that. So we need to take all of these, dimensions into consideration as we're making an appropriate recommendation for level of care. We need to be able to justify our recommendations clearly. This is not just about making a decision. It's about explaining why that decision is appropriate. And writing clinical recommendations is where your assessment and your treatment planning are coming together in a very visible way. So this is a part of your work that other professionals are often going to read and rely on, and sometimes they're going to challenge you on it. And because of that, your recommendations need to be clear and specific and well supported. A strong recommendation does not just say what the client should do. It explains why. So, for example, instead of just saying client should attend treatment, you need to say something like, based on the client's history of continued use despite consequences and high relapse potential and a limited support system, ASAM Level 1 outpatient treatment is recommended at a minimum of once per week for 6 to 12 weeks. That level of specificity is going to matter. It's going to show that your recommendation is grounded in clinical reasoning, and it's going to make it easier for the courts and the probation officers or employers or other providers to understand your decision. And another important point here is that recommendations should match the assessment. If your assessment identifies severe issues, but your recommendation is minimal, there's a disconnect. So as counselors, we need to ensure consistency between what we're observing and what we're recommending. And that's going to build credibility and improve outcomes. So there's several common errors that show up in clinical recommendations, and being aware of them is going to help you avoid weakening your own work. So one of the most frequent issues is being too vague. Statements like, client would benefit from counseling. It doesn't provide enough direction. And another issue is a lack of justification. If you can't clearly explain why you're making that recommendation, it's not going to hold up under review. So, also over-recommending is a concern. Recommending a higher level of care than necessary is going to reduce client engagement and create unnecessary barriers. And then on the other hand, under-recommending can leave the client without enough support. If we ignore key factors, that's another major problem. If your recommendation doesn't address relapse risk or mental health or their environment, it's incomplete. As counselors, we need to be intentional and thorough in this process. So let's take all of the theory and the frameworks and the terminology from this lesson and actually use it in the way that a practicing counselor would use it in the real world. So case practice is essential because treatment planning and level of care decisions are not skills that you master just by reading the definitions. You master them by repeatedly looking at client information, organizing what matters, and making a clinical decision that you can defend. So when you approach a case, your first step really needs to be to slow down and review the client information carefully. Don't just jump straight into a recommendation just because the client uses a certain substance or they have a certain legal charge. You need to look at the full picture. What's the actual pattern of use? What are the consequences? What is the current stability level? What mental health concerns are present? What support system is available? What's their relapse history? Then we're moving into identifying the relevant ASAM factors. This is where you are mentally sorting the information into 6 dimensions. Are there withdrawal concerns, biomedical concerns, emotional or behavioral instability? Is there low motivation? Is there a high relapse potential? Do they have a poor recovery environment? And once we can do that, the case usually becomes more clear. We start to see not just that the client has a problem, but what kind of support they actually need. And then the next step is determining the level of care. So this is where a lot of the counselors either overreact or underreact. And some assume that because a client has serious consequences, they automatically need residential care. And others minimize risk because the client's functioning in some areas of life. So your job is to weigh that risk and severity and support. You know, we're supporting their needs in a balanced way, basically. And then comes the written recommendation. So this should be very direct, specific, and justified. We're not just naming a service, we're explaining the reasoning behind it. So, for example, I might say something like, given the client's repeated return to use after prior treatment, limited sober support, and elevated relapse potential, a more structured outpatient setting, such as intensive outpatient treatment, is recommended. That's stronger than just simply saying IOP recommended. And when you practice cases this way, you're strengthening your ability to think clearly under pressure and, make recommendations that are holding up clinically and ethically and sometimes legally. And this is also the skill that makes your evaluations more than just paperwork. It makes them actionable. I want you to think through to maybe one client that you've actually seen in the past. Think about which ASAM dimensions are most elevated and what level of care logically follows with that client. This kind of applied reflection helps this material stick much better than just a passive review. So if you can actually apply it to one of your clients, I think that it would stick better for you. So I want you to ask yourself a very direct question here. How confident am I when I make treatment recommendations? Not how confident do I sound, and not whether I can fill out the form, but whether I genuinely understand and can defend why I'm recommending a particular level of care or approach. Some counselors realize that, they've been relying heavily on habit, templates, or, what you've seen other people do. Others realize that they're strong in assessment, but they're less confident when it comes to translating the assessment into a clear plan. Some of you may notice that you tend to recommend because you're afraid you miss something. And some of us under-recommend because we're trying to keep the clients engaged and avoid conflict. And this reflection is really designed to surface those patterns. I'm not trying to create shame here. It's just meant to build awareness because awareness is what's allowing growth. So think about recent cases where you felt certain in your recommendation and cases where you felt uncertain. What made the difference there? Was it a lack of information or a lack of structure in your reasoning? Was it uncertainty about the ASAM dimensions? Or was it just discomfort with recommending a higher level of care? What specifically needs improvement? Do you need better assessment questions? A better understanding of relapse risk? Do you need more comfort writing concise but well justified recommendations? Maybe you need more confidence speaking about your recommendations to courts or probation or families or referral sources. So your reflection should lead to the next practical step, which, for example, a participant might realize, I need to get more precise about connecting my assessment findings to measurable treatment goals, or I need to stop using vague language in my recommendation. That would be a useful reflection. So write down your answers. rather than just thinking about them briefly. Written reflection tends to be a little bit more concrete and honest. And so we're setting up our lesson here. And I just want to remind you that treatment planning is not just a technical skill, it's a clinical judgment. And, like all clinical judgment skills, it's going to get sharper when we're willing to examine how we're currently making decisions and where our blind spots may be. So I want to make a really important point here about where a lot of counselors struggle. There's this gap between assessment and action. So a lot of clinicians are really good at gathering information. We can conduct a thorough intake and document history and identify concerns with the best of them. But then the treatment plan doesn't really clearly reflect what was found. So bridging that gap is going to require a structured thought process. First, we want to take our assessment findings and translate them into needs. So, for example, like if a client reports daily alcohol use and previous failed attempts to quit and they've had legal consequences, the need is not just simply reduce the drinking. The need is structured intervention for substance use and relapse risk. And so we then need to translate those needs into goals. And the goals should reflect meaningful change, such as like the client needs to achieve abstinence or improve coping, or maybe I need to help them stabilize their functioning. And then after that, then we break down those goals into interventions. So what are you actually going to do in session? Are you using relapse prevention, cognitive behavioral therapy, psychoeducation? Are we doing skill building? What are we doing? And then we need to define what are our outcomes going to be? How do we know that this is working? This is where the measurable objectives matter. So as counselors, we need to slow this process down and be intentional here. So, I might say in session, like, based on what you've shared, I'm hearing that the biggest area we need to focus on is your relapse risk and stress management. Let's build a plan around that. And that kind of transparency helps the client understand the plan and it increases their buy-in. And when you're consistently moving through this chain, we're finding the needs and then the needs to the goals and then the goals to the interventions. Your treatment plan becomes much stronger and much more defensible. So measurable objectives are one of the most overlooked parts of treatment planning, but they're also one of the most important. Without measurable objectives, we can't clearly determine whether progress is being made. A strong objective is specific, observable, and time-bound. So for example, instead of saying client will improve coping skills, you might say client will identify and demonstrate at least 3 coping strategies to manage cravings within 4 weeks. So that gives you something that you can actually track. And we need to ask ourselves as clinicians, if I read this objective in 30 days, will I know whether the client has made progress? If the answer is no, then the objective needs to be revised. Another important factor is making sure that the objective is linked directly to the goal. So if the goal is relapse prevention, the objectives really should clearly support that outcome. So this might include identifying triggers, maybe practicing some coping strategies or increasing support engagement. We also want to make sure that the objectives are realistic, because if they're too difficult, the client's going to get discouraged. And if they're too easy, they may not produce meaningful change. And that's where the clinical judgment is going to come in. So in session, you might say, you know what, let's break this down into something a little more manageable. What's just one step that you feel confident that you can work on this week? And that collaborative approach is going to help the client feel more involved, and it's going to increase the likelihood of follow-through. Measurable objectives are going to turn your treatment plan from a document into a working tool. Intervention planning is where your clinical skill becomes most visible, because this is what you're actually doing with the client. It's not just enough to say that you're going to address substance use. You need to define how you're going to address it. This is where evidence-based approaches come into play. So for example, cognitive behavioral therapy helps clients identify and change their thought patterns that lead to use. Motivational interviewing really helps increase the readiness to change. Relapse prevention strategies, they're going to help manage the triggers and cravings. So the key is matching the intervention to the client's specific needs. So a client with high relapse risk needs different interventions than a client who's in early experimentation. And another point I want to make here is structure. Your interventions should not feel random or reactive. They should be tied to the treatment plan and revisited consistently. But flexibility is also important. If something's not working, you need to adjust it. And that's where ongoing assessment comes in. So maybe you say, we've been working on coping strategies, but it sounds like they're not helping in the moment. So let's try a different approach and see what fits better. This kind of adaptability is going to strengthen your effectiveness, because intervention planning, this is where the theory is meeting the practice. And it's one of the most important skills that you can develop as a counselor. So determining how often a client should be seen and how long treatment should last is another critical part of treatment planning. This decision should not be based on convenience or default settings. What does my company provide? It's based on risk. It's based on severity. It's also based on need. A client with a high relapse potential and limited support, and that same client has active stressors, they may need more frequent sessions, possibly multiple times per week, or maybe even a higher level of care. A client who's stable and progressing well may do fine with weekly sessions, but the duration is also important. Some clients may need short-term intervention, while others require long-term support. So as counselors, we need to be honest about what the client needs, even if it is more intensive than they expected. And it's especially important, in court-related cases where under-recommending can create liability. So we might say, based on what we discussed, I recommend meeting weekly for at least the next 8 to 12 weeks so that we can build consistency and reduce relapse. And that kind of statement's clear and it's justified. It also helps to set the expectation. Treatment's not static. Frequency and duration should be reviewed regularly and adjusted as needed. And that ensures that the client's receiving the appropriate level of care and level of support over time. And documentation is not just a requirement. It is a reflection of your clinical thinking. So in a lot of cases, your documentation is going to be reviewed by courts, probation officers, licensing boards, other professionals, and that means that it needs to be clear and consistent and defensible. Clear language is essential. We want to avoid vague statements and be specific about what we're observing and what we're recommending. Clinical justification is also critical here. Every recommendation should be supported by assessment findings. Consistency is another key factor. If your assessment says one thing and your recommendation says another, it raises questions about your reliability. The professional tone is going to matter as well. So your documentation should be objective and focused on behavior, not opinion. So for example, instead of saying client is irresponsible, you would say client reports missing 3 scheduled sessions and failing to follow through on assigned tasks. That's going to keep the focus on observable behavior. Because as counselors, we need to think of documentation as part of our clinical responsibility. It's not just an administrative task. Strong documentation protects you, it supports the client, and it's going to improve communication with other professionals. So we want to make, when we make a recommendation, this is only part of the process. We want to communicate it effectively to the client. And that's where a lot of counselors are struggling, especially when the recommendation involves a higher level of care. The way you're presenting the recommendation can influence whether the client accepts it or resists it. Clear explanation is the first step. So the client should understand what you're recommending and why. I'll give you an example here. I had a client a couple weeks ago that she said, oh, I need this evaluation. And so we did the evaluation and I recommended one level of care for her. And she said, no, I don't need that level of care. And I explained to her why I was recommending the level of care. Hey, this is what's required for this. This is, the reason why I said this. And she said, oh, that's great, but the court recommended XYZ. I understand the court recommended XYZ. My recommendation is something completely different, but if the court is saying that you have to complete this particular thing, then they have to comply with that. And so I'm going to change my recommendation based on the court's order. Unfortunately, sometimes we have to do that. We also want to avoid overly clinical language and explain it in a way that is relatable. So a collaborative tone is also going to be important. Even though we are the professionals, the client should feel involved in the process. So I might say, based on everything that we've talked about, I'm concerned about your risk level, and I think a more structured program is going to give you the support that you need. So let's talk about what that would look like. We also want to look at how we're addressing resistance, because addressing resistance, that's part of this process. Clients are going to push back, especially if the recommendation feels overwhelming. So instead of arguing, we want to explore their concerns. We want to reinforce your reasoning without becoming defensive. That's going to help maintain the therapeutic relationship while still holding your clinical position. I've had to tell people, no, my recommendation stands, and this is the reason why I'm recommending what I'm recommending. So we need to know when to increase our level of care, or the client's level of care. That's really a critical skill here, because it's requiring both the observation and the willingness to act. And one of the most common indicators is increased relapse risk. If the client's showing signs of emotional or mental relapse, or they've already returned to use, that may indicate that the current level of care is not sufficient. So looking at lack of progress, that's another important factor. If the client's attending sessions but they're not making meaningful changes, it may be time to adjust the approach. Safety concerns, these should always be taken seriously. This includes risk of overdose, severe withdrawal, mental health crisis, whatever. And then environmental instability, this is another major consideration. So if the client's environment is actively undermining their recovery, or it's just interfering with them being able to continue forward in treatment, really, maybe a higher level of care may provide a little bit more structure. And as counselors, we really need to be proactive rather than reactive. Waiting too long to increase the care can really make the situation worse. So you might say something like, hey, I'm noticing despite the work that you're doing, you're still struggling to stay stable. So I think it might be helpful to add a little bit more structure and support at this point. And that kind of statement is clear, and it's supportive, and it's clinically appropriate. It's not punitive. So stepping down care, this is just as clinically significant as increasing the care, and it requires the same level of thoughtfulness and justification. And one of the most common mistakes counselors can make is stepping down clients too quickly because things appear to be going well in the short term, or because this level of care is only this long and the client has to step down at this point because that's what our treatment program says. I literally have seen someone who passed away due to overdose because they were stepped down too quickly. And the justification that was made at that time was, well, we can't keep them in IOP forever. So short-term improvement is not the same as stability. So when you're considering stepping down a client, you need to look for consistency over time. Has the client maintained progress across multiple weeks or months? Are they demonstrating the same level of stability in different situations, or only when conditions are ideal? Another key factor is whether the client has developed and is actively using their coping skills. It's not enough for them to know the skills. They actually need to be applying them independently without you constantly prompting them. A strong support system, that's also critical at this stage. So when the level of care decreases, the client's going to have less direct clinical contact, which means that their external supports become a lot more important. So you want to ask yourself, if this client has a difficult week, who are they going to turn to? How are they going to manage without the current level of structure? Improved functioning, this is another important indicator. Is the client consistently attending work or school? Are they managing their responsibilities? Are their relationships stabilizing? These are all signs that stepping down may be appropriate. But we also want to assess for hidden risks. Some clients can present as stable in sessions while still struggling in their environment. And this is where asking the detailed questions become important. So we might say something like, hey, walk me through what a typical evening looks like for you now. Or what situations still feel difficult to manage. And when you communicate a step down decision, we also need to it should feel like a progression, not a withdrawal of support. So maybe we say something like, hey, you've been showing really consistent progress, and I want to support you in taking the next step while still making sure you have structure in place. And it's going to be important for us to frame the step down as flexible. And the client understands that, if things change, the support can increase again. And that reduces their fear and it helps maintain that engagement. Clinically, we should be documenting clearly why the step down is appropriate. We need to include the specific improvements that we observed. And that's really going to strengthen your documentation and ensure the continuity of care. Because stepping down is not about doing less. It's about doing what's appropriate for where the client is right now. Coordinating care is one of the most important and often underutilized aspects of effective treatment planning, because very few clients with substance use issues only need one type of service. A lot of them are going to require a combination of counseling and medical care and psychiatric support and case management and sometimes legal or social services. And so your role as a counselor is not to do everything, but to make sure that everything the client needs is connected and working together. So referrals are going to be your starting point here. But just simply handing the client a phone number is not enough. You need to assess whether the client is actually able and willing to follow through. So that might include discussing transportation or cost or insurance or scheduling and emotional readiness for them to even do that thing. And then you might say like, what would make it easier for you to follow through with this referral? Collaboration with the providers is the next step. So when it's appropriate and with the proper releases, communicating with other professionals is going to help ensure consistency in treatment. So for example, if a client is seeing a psychiatrist, it's going to be helpful to know whether medications are being taken as prescribed and whether there are concerns about side effects or adherence. Continuity of care is really, really important during transitions. When a client is moving from one level of care to another, there should be a clear handoff. And that might include like sending records or communicating with the next provider or like preparing the client for what to expect at a bare minimum. And then follow up is what's preventing the clients from falling through the cracks. So after making the referral, we want to check back in. We want to ask, were you able to connect with that provider? Or what barriers came up? This shows the client that the referral matters and that you're invested in the outcome. And clinically, coordinated care improves outcomes because it's addressing the full picture rather than the isolated issues. And it also strengthens your role as a central support in the client's recovery process. And when we do this well, coordination is creating a network of care that's reinforcing the client's progress rather than leaving them to navigate these systems alone. Ethical considerations, these are woven into every part of treatment planning and level of care decision. Whether we are explicitly naming them or not, one of the most important ethical responsibilities that you have is recommending the appropriate level of care based on clinical need, not just convenience or pressure or assumptions. And that can really be challenging when clients resist higher levels of care, or when external systems like courts or employers have expectations that may not align perfectly with clinical judgment. So your role is to remain grounded in what's clinically appropriate. Avoiding the bias is another critical ethical component here. bias really does show up in subtle ways, like assuming a client is more or less severe based on their background or their appearance or their communication style. And it also shows up in how much effort we put into planning or how we interpret behavior. Being aware of your own biases and actively working to counter them is part of our ethical practice. Client autonomy is also central. While we make recommendations, clients ultimately have the right to make decisions about their treatment. But autonomy doesn't mean stepping back completely. It means ensuring that the client is making informed decisions. So I might say to the client, yeah, you have the right to choose your path, but I want to be clear about the risks so that you can make an informed decision. Professional responsibility includes documentation, communication, and consistency. If your recommendations are challenged, you need to be able to explain them clearly and confidently. Ethics isn't just about avoiding mistakes. It's about practicing with integrity and clarity and respecting the client, but also maintaining our clinical standards. So case integration, this is where everything in this lesson comes together into just a single cohesive process. This is a skill that's separating surface level understanding from true clinical competence. When you can approach a case, you're not just we're not just looking at the isolated pieces of information. We're building a complete picture here. So we want to start with the full assessment review. That means looking at substance use patterns, we're looking at mental health, medical issues, social environment, legal involvement, what's their current level of functioning, and then we want to apply the ASAM dimensions. This is going to help us organize the information and identify areas of risk and need. So for example, you might identify moderate withdrawal risk or significant mental health concerns, low motivation, high relapse potential, and a high risk environment. And once you see that pattern, that level of care decision becomes a little bit more grounded. You're not just guessing, you're responding to the identified needs. Then you're determining the treatment plan. What are the client's goals? What are the interventions that are needed? How often should sessions happen? What additional services are required here? And then justify your decision. This is the part that a lot of counselors skip or they rush through, but it's essential here because you need to be able to explain your reasoning clearly. So you might say, given the client's relapse history and a limited support system, a higher level of care is recommended to provide additional structure and reduce the risk. And this level of clarity is especially important in court or professional settings. Case integration is not just this quick process. It's going to require practice and reflection and repetition. But once you develop this skill, your confidence and effectiveness as a clinician is going to increase significantly. So as we summarize this lesson, I want you to focus on a few key ideas that should carry into your daily practice. First, treatment plans are not just paperwork. They are the structure that guides your work and the client's progress. And when they're done well, they're going to keep the sessions focused and purposeful. Second, ASAM-informed thinking helps you make even better decisions, even if you're not formally using ASAM documentation. So thinking in terms of risk and severity and support is going to improve your clinical reasoning. And then third, recommendations need to be justified. It's not just enough to say what the client should do. You need to explain why they should do that. And that's going to strengthen your credibility and ensure that your work holds up under review. Another important takeaway is that clinical thinking needs to be structured. We should be able to move from assessment to needs to goals to interventions in a logical and consistent way. That's going to reduce the guesswork and improve the outcomes. And I also want you to think about how these takeaways apply to your current work. Where are you already strong? Where do you need to improve? These questions are going to help turn your knowledge into practice. Strong treatment planning is just one of the most valuable skills that you can develop as a counselor. So for this assignment, I want you to take a real or a hypothetical client and I want to walk through the full treatment planning process. We want to start by identifying the key assessment findings and then translate those findings into specific needs. From there, you can develop some clear goals and measurable objectives. Then I want you to determine the appropriate level of care using ASAM-informed thinking. This is where you're considering severity, risk, and support. And once you decide on that level of care, I want you to write a recommendation that includes both the level and the justification. Don't just skip the reasoning. That's the most important part. And then I want you to identify the interventions that you would use in the treatment. So be specific about what you're actually going to do in sessions. And this assignment is designed to help you practice the full process, not just individual parts. So take your time with it. Be intentional. This is the kind of work that directly improves your clinical effectiveness. If you're not currently working with clients and you're still in training, you can use a TV character to do this assignment over. So I just want to give you an opportunity to consolidate what you've learned and connect it directly to your practice. So I want you to start by identifying what improved in your understanding. Do you feel more confident in connecting assessment to treatment planning? Do you feel more structured in your thinking about the levels of care? And then I want you to think about what you're going to apply immediately. This might be writing more specific objectives or improving your recommendations, or even using the ASAM dimensions more intentionally. And then I want you to consider where you still feel uncertain. And that's important because it's going to help you identify some areas for continued growth. And then lastly, I want you to think about how you're going to improve the process moving forward. So maybe this is slowing down during assessments, or reviewing your treatment plans more carefully, or seeking feedback from your colleagues. Reflection is what's going to turn your learning into a lasting change. So as we close this lesson, I want to emphasize the growth that comes from developing these skills. You're learning how to structure treatment in a way that's clear, intentional, and clinically sound. You're learning how to justify your decisions, which is critical in professional practice. You're also learning how to match clients to the level of care that best meets their needs. These are not small tasks. These are core competencies that define effective counseling. Confidence in this area does not come from memorizing information. It comes from applying it consistently and reflecting on your own decisions. So as you're continuing to practice, this process is going to become a little bit more natural, and you're going to be able to move from uncertainty into clarity, and from hesitation to confidence. And that growth, you're going to benefit from it, and so will your clients. So as you're completing this lesson, read each of the study guides in each of the lessons that are printed, and then you'll be able to pass your tests from those study guides. So once you complete the test, then your certificate should pop up.